Good evening. I'm Anthony Bainham. I'm one of the ambassadors for UOK-Doc. I'm a psychiatry trainee in Manchester. This evening we've got Professor Shekhar Saxena, who is a professor of global mental health at the Harvard T.H. School of Public Health at Harvard University. He previously was the director of the Department of Mental Health and Substance Abuse at the World Health Organization between 2010 and 2018, and had worked at the World Health Organization since 1998. Prior to this, he worked as a psychiatrist and has authored over 300 scientific papers. And he is a core member of the First Responders First initiative, who are our brilliant partners in this webinar series, the Micro Steps webinars. We'd like to thank him so much for coming on this evening. Without further ado, I'll hand you over to him.
Thank you, Anthony. Welcome, Shekhar. I think one of the other things just to mention is how instrumental you've been in helping us with the other people in the webinar, Paul, the CEO of Mind, and so on. So thank you for that. And also just thank you for giving some of your time to help us in the development of the charity and the promotion of it and so forth. One of the things I particularly wanted to focus on tonight, and I know it's a particular key thing for you, which is about systems, the responsibility of systems within which individuals, teams work in various different medical settings. So it's going to be great to be able to go into a bit more detail about that with you. One thing I did want to because I'm always interested in how people are drawn to this work. Do you remember the first time you knew that this was a sort of area of work that you felt passionate and wanted to get engaged in?
Thank you very much, Chris, for inviting me. Thank you, Anthony, for introducing me very generously. I'm really delighted to be part of this conversation because I do believe that mental health and well-being are extremely important at all times, but especially during these times, and especially for the care providers who are in some ways struggling with coping up with the effect of the pandemic and are finding sometimes difficult, sometimes impossible, but never very easy to do the things that they are being asked to do. So I'm delighted to share some of my thoughts, but also have a discussion so that I take back some key messages from this discussion. Chris, you asked me a question about when did I start thinking about that, and I assume that it's about mental health as a field. Yes. And as I was introduced, I'm a psychiatrist by training. So I did my medicine in my home country, that is India. And almost from the first few months of my beginning the medical training, I was very clear that I did want to go into psychiatry as a specialty. And what fascinated me at that time was just how little was known about psychiatry. One tended to pay attention to some of the other areas with a kind of definitiveness, which somehow I found a little bit missing here. So it was more an intrigue, it was more trying to find out more, and of course, to help people more who are some of the most neglected and ignored people within the entire health system. So that's what fascinated me, and that's why I chose psychiatry, and I have never regretted it, actually.
And which period of time are we? Which decade are we talking about when that was happening?
You're asking me my age, but I have no hesitation in saying that. That was late 70s and early 80s.
I mean, it's partly asking you because things have changed so profoundly, and they continue. I mean, that's part of why we're talking, is the continuing evolution and development of how we bring mental health, emotional well-being to the center stage in all our well-being. Yep. But you must in that period, you very quickly, in some ways presumably intuitively, saw things that really needed to be addressed or begin to be looked at in a different way?
Absolutely. In fact, you are absolutely right that the knowledge gain in the period of about 35, 40 years since I had that initial thought has been tremendous. It has been one of the most steep learning curve for me and many of my colleagues, because the accumulation of knowledge has been great. And also, I should actually confess that during my work as a psychiatrist and then work in the public mental health in WHO, what I felt very strongly was that as the knowledge gain was very profound, the use of that knowledge for changing policies and practice has actually not kept pace. So that is one of the things that I think we need to really pay more attention to. How can we use the knowledge that we already have? We keep saying we need more, but in spite of the fact that some of the very much evidence-based psychiatric medicines as well as psychotherapies have been discovered and developed and perfected decades back, we do know that 80% of the people globally do not have access to that. So that's what really is something that we need to all think about. And coming back to the discussion for today, we also know a lot about how some of these crises affect population and affect also healthcare providers. But we're doing very, very little for that. And that's what we really need to gear up and do much more.
And the immediate obvious things to address, are they clear? I mean, with all that, those years of understanding and insight, is it still clear where you need to start to pay attention to things?
I think it's reasonably clear. I would say that we know what to do. We are just not doing it at the scale that is needed. There are beautiful, very nice projects, pilot projects, service delivery mechanisms, programs, which do extremely well. We are just not doing it at a scale that is needed. And obviously, having a global outlook, I would say that many of the high-income countries still have very many low resource settings and neglected populations. So even they are not doing well. In fact, I am very fond of saying that when it comes to mental health, all countries are developing countries, because none of them can boast having a system that really caters to the needs that their population have. So there is a lot of inequities, there is a lot of disparities in access to service and the quality of service that we still need to struggle with in the most resourced countries also.
I mean, I'm sure the people that you've been talking to over the years, advocating and illuminating, informing people, are there common ways in which prejudice or judgment or views have hindered the development of programs?
Yes, I would say there are three important factors which have hindered. One is the all-pervasive stigma, which obviously has decreased, but is still there very much so. Second is lack of enough investments, that many countries invest too little on this. And of course, if you don't invest, you don't get any gains. So that is one of the major things. But lastly, there is also what I regard as a lack of openness about learning from others in other situations. That is one of the things. There are so many innovations being tried out in low and middle income countries that are not picked up by high income countries and vice versa. So it should be a two-way, in fact, a multi-way process of learning, especially from innovations. And that doesn't seem to be happening at a scale that is needed.
I mean, do you have some of your own examples of innovative mental health, emotional well-being plans, projects that you see could be usefully brought into the systems that we have, say, in the UK?
Absolutely. The UK is obviously doing quite well, so I should not pick on UK because there are many other countries that are not doing so well. But still, the example of what has been tried in Africa as what has been called the friendship bench model, where trained lay people can actually counsel a lot of other people and take care of not all, but many of the mental health problems, is something that is extremely inexpensive, very easy to do, has a lot of uptake in the situations that it has been tried. And that still is not something that we are using widely, although some countries and some cities, including New York, for example, is trying it out now. But there are papers which describe the scientific validity of this kind of model. And is still being very inexpensive. It's not being picked up. And I would be even going ahead and saying that the reason for not picking up innovations sometimes is just vested interests. Psychiatrists everywhere think they know the best. I happen to be a psychiatrist, but I have no hesitation in admitting that there is a sense of knowing all arrogance that really impedes the picking up of ideas, sometimes which seem too simple to be working, but actually they might work very well. And that's something that we really need to start doing.
I know we were talking earlier about first responders first, and I mean, both to me and to our audience. Tell me again about this project that you've got in development that you're launching in January.
Now, First Responders First is an initiative that was started by Harvard T.H School of Public Health, which I belong to, and also Thrive Global, which is an international organization but based in US, and Creative Artist Agency, which is an agency dealing with very many celebrities, including from Hollywood. And we joined hands together way back in April to, in fact, in March, to really think through what the frontline workers are experiencing as a consequence of the pandemic and how can one help them. And these are frontline, mainly public health workers and clinical workers, but also sometimes from outside. And we recognized that these people are already facing, even at that time, a very major stress, because when everybody else was being asked to stay home, these people were asked to actually go to the front line and work not only normally, but extra, and handle situations which were extremely difficult. So we worried about the mental health and well-being consequences to these people and the eventual effect on the public health care system itself. And so we started that. And we have now had more than 10 months of experience in this area. And we have tried to help a lot of people with material, with micro steps, which is something that you are using, and also with many more strategies to prevent stress, to take care of stress, to provide help when needed, even clinical care, and also make them more aware that this is an important part of your life, an important part of your professional duty that you should not ignore. And we have made tremendous success, but we still realize that there is a certain hesitancy, a certain reluctance in healthcare providers to actually look at their own mental health and well-being. One, they may not know that this could be a problem. Even if they know, they hesitate to take help. When they're providing help to everybody else, they fail to take care of themselves, which eventually has a major impact. They might burn out, they might have a problem. In fact, there have been certain acts of suicidal deaths amongst these people, and all of that is avoidable. So we believe that a lot more can be done and should be done. And with that spirit, we are actually coming to you and seeing how you can actually do what you can in UK as we are expanding our scope of work in US. But just to add one last point, to take care of this reluctance, to this hesitation in recognizing and taking help, we're actually thinking of a campaign starting early next year, where we will directly confront this kind of barrier to care. Why should people not recognize that they are also vulnerable? And also by calling these healthcare workers as heroes, we're actually putting the dice against them, because heroes don't take help. And that's something that we are actually reinforcing by putting them on a pedestal, by calling them heroes as if they were not human beings. Mm. And they need to recognize that they are as human as anybody else. They're as vulnerable as anybody else. And although they are doing a superhuman job, but they must look after themselves. So that is something that we're planning and we think will be extremely useful, not only for the US, but for the entire world.
Yes, yeah. I mean, am I right in how I'm understanding what you're saying, that there's two components? There's the system, there's the organization, and then there's the individual. Because you're sort of, as an individual, you have to see it as a really positive step if you're feeling emotionally challenged or struggling. And then there's the system, that how they meet the individual, how they provide the right environment, the services, the setup to make that well, that it doesn't add to any of the problems that a person's already experiencing in coming forward. Is that what you were?
That's right. I was so far focusing on the person.
Yeah.
But a very important aspect of this whole issue is the work environment and the organizational and institutional systems, structural as well as functional, yes, which are there. And I think, in fact, with that in mind, I suggested the title as the medic within the medical system. So we have spent a lot of time and energy and resources to assist people. But I think a relatively less amount of effort has gone into understanding the environment in which these people work and what can be done to actually, from the institutional and organizational side, to assist them in taking care of their own mental health and well-being. So there are certain responsibilities which the organization has to fulfill. And here I would just like to make one point that is not only in the interest of the healthcare workers, professionals, doctors, nurses, other people, that they remain mentally healthy and their well-being is looked after for themselves. But it's in the interest of the entire organization, in fact, in the interest of the entire public healthcare system, that this needs to be protected and cared for.
Do you never get just frustrated? But I mean, it's just so clear, isn't it? And yet you're having to, again, articulate and advocate for something that, you know, from the 70s you saw the need for. And I know things have changed, they're developing and so forth, but there must be moments of frustration at what just is so obvious that we need to do.
Well, one of the lessons that one has learned working in the area of public health is not to get frustrated, but keep trying. But yes, it seems so obvious that, you know, we read amongst the mission and the vision of each of these organizations that I deal with, that human resources are their best assets. Now, if we don't look after the mental health and well-being of the very same human beings, yeah, who are the assets, are we not really dwindling our precious assets? Are we not looking at a future where these very assets will be burning out?
Yeah.
And that will affect the care of the patients, that is top of our minds. And also the profits, which sometimes these organizations are looking at. Some organization, not non-profit organization, which is fine, but some of the organizations which provide healthcare have a profit center, and they need to justify the care that they give, but also for the revenues that they generate. And this directly affects their bottom line. So it should be a very easy argument to make, but unfortunately that is not happening. And we need to continue to make that effort.
Yeah. Is there a clear path that you draw upon, because you're talking about the monetization of mental health in a way? Are there ways in which that can be reframed, that just in terms of the monetization of it, that you can still look at this differently and still your bottom line is going to stay stable?
Well, I will answer this question in two ways. Having worked for WHO for 20 years, I would say health, which includes mental health, is its own value. So we should be doing things for mental health and well-being for ourselves and for the populations because it is important and it is its own value. However, some of us, including the finance ministers and the banks and the organizations, are very keen to see health as a mediator towards money. So they're not counting disabilities, they're counting dollars or pounds. And that is also something that we need to look at, although I don't put that as my first priority, but I do understand that people have that as a priority. And there the argument is again very simple, that if you don't look after the mental health and well-being of your doctors and nurses, they will get too much stress. They will not be as effective as they would be otherwise, and they will burn out earlier. There will be early retirement, there will be early pensions, there will be compensation claims, and your effectiveness as an organization, as a healthcare organization, will suffer, and you will suffer financially. So it's in the interest of people, it's in the interest of organizations' effectiveness, and it's in the interest of the economies that we actually pay attention to that. We have heard these reports that in any country that I look at, a number of healthcare providers have actually died because of COVID, because of lack of protection. And so protection of the people, very people who serve, is extremely important. What we are not hearing that much is that many of them are at the end of their tether in terms of their mental health and well-being. And that needs to be looked after, because that impact might come a little bit later. Death is obviously very visible. Burnout becomes visible in due course of time, in months, in sometimes in years, but that's going to have a much larger impact on the effectiveness of the healthcare system than what we are seeing now. So we need to plan for today, and we need to plan for the months and years to come.
Do you think COVID in its own way has accelerated the necessity for giving attention to mental and emotional well-being? Like how quickly the vaccines have been created, just such leaps. Do you think in its own way COVID has accelerated our understanding and awareness of emotional and mental well-being?
Yes, many times it requires a crisis for us to attend to a problem that has existed for a long time. Yeah. And yes, I think if there can be any silver lining to the pandemic, it's very difficult to imagine. Yes. But this might be one, that we are now paying much more attention to our own mental health and well-being and of our colleagues. And that has come out sort of much more into the open. We are talking about it, we are discussing that, and sometimes we are even taking care of that, which actually is a very positive development. And also it has become, the discussion has become more normalized. So instead of talking about some people who might have a mental disorder, we are talking about ourselves. Yes. Which is a very healthy trend, because we regard mental health as a continuum. You are somewhere on that continuum. You might have good mental health, you might have difficulty in coping up, you might have a mental health symptom, you might have a mental health disorder or a disability. And the pandemic is moving the spectrum towards the right. That means if you were able to cope very well, you have some difficulty in coping now. And if you had a mental disorder, you have more disability. And I think pandemic has helped us to understand this, this dynamic spectrum and also to do something about it, which I think is a very positive development.
I mean, the sense of mental, emotional well-being becoming a much more proactive, the attention now being more focused on proactive, preventative sort of resources. Do you have some of your own thoughts about, well, specific to the UK perhaps, but maybe, you know, it's just generically relevant to a number of countries, the sort of resources that in more detail you see as being needed?
Absolutely. We need more resources at all levels. One, we need to invest more ourselves, and this applies especially to doctors and nurses, that we need to really take this more seriously ourselves and invest into it in terms of our time, our mind space, and our effort. And we are not doing that. We are measuring how many steps we take during the daytime. We are measuring how much sleep we get. We are measuring our cholesterol every few months, but we are not paying attention to the stress levels that we have. And so that we need to do at an individual level. At an organization level, we need to pay attention to how our workforce is doing in terms of the stress, in terms of the mental health and well-being. And we need to have a barometer for that. We need to measure it. We need to talk to people and attend to that, because sometimes it remains unseen and below the radar. And finally, the impact is quite massive. So as organizations, we need to be paying attention to that. And as communities and countries, we need to invest much more in that as systems and also as finances. So that's where, to my mind, the whole thing becomes much more responsibilities of the communities and organizations besides ourselves. And that is really very important for us to look after.
I mean, just briefly, I mean, that arm of the first responders, the celebrities or people with public profiles, do you think that's changed in the last decade or recent years, where you've been actively able to use these public people who represent various things to people?
Enormously, actually, Chris. Good that you're asking that, because a few decades back, I don't remember any celebrity, any well-known public figure coming out and saying that I have a mental health problem. But now people do that. We have famous actresses, actors, we have sports people, we have writers coming out and saying, I have this problem, or I had this problem, and this is the way I could help myself. And that really makes a very major impact. So we are using all methods, and we are in a way supporting people who want to come out with these kind of self-statements and stories. And just coming back to our audience, as doctors, as nurses, we need to do it ourselves. So I would be delighted. It will be a very good example if the CEO of the hospital or the trust comes out and says that I'm facing a stress and this is the way I am handling it, and opens a dialogue with the staff to say, are you also having that? And what can I do? What can we do about it? Which is where the organization's responsibilities are. And good stories, good self-descriptions of that goes much more than a couple of memos written very impersonally and saying, if you have a problem, talk to this person, get on to this email, which is helpful. But I think a personal story is much more helpful. So I would very much like, if there is anybody in the audience who is in that situation, in that kind of responsibility, to actually set an example for that.
It's so nice if people were to go back over the webinars, how much what we're talking about is in its own way directly connected to some of the conversations we were having in the past, and one of them about leadership and leadership, the people who are in leadership positions, some of the opportunities and possibilities that they have in leading the way regarding mental emotional well-being. So I'm just reminded of that when you speak of that. Just briefly going back to one thing, you were talking, because it's very interesting about gathering of data, whether it's sleep or your steps, which, you know, they've got their own value in terms of tracking, you know, to some degree how we are. Have you got some other suggestions that you have that would be useful for people to pay attention to as a more fuller assessment of their own well-being?
Yes, in fact, that brings me to quick self-assessments, but also micro steps which can help.
Yeah.
We know that doctors and nurses and all medical care providers are very busy most of the time, but especially during these times, sometimes they're doing double duties, they are looking after many more patients, and they have just lack of time. But there are certain things that they can do which doesn't take that much time. It might take between a minute and 5, and even if done 3 times a day, that can extremely be useful. One of the things that we are suggesting is to really take a few minutes in the morning to plan your day as much as you can. Sometimes things happen which you have no control over, but plan a day and look after the fact that you do need breaks in between. You do need to look after your nutrition, for example, or hydration, and take time for that. So that you plan for that and not take it just as it comes. The other thing is in the evening, after you finished all your work, can you just take off all your work and look after yourself and maybe others in the family, to take a few minutes, make a phone call with somebody you want to ask how they are, taking the line from you, are you okay? And that really helps not only the person that you are asking, but yourself actually, because you're taking your mind off from your work stresses. And late in the evening, one can go through the day and just recapitulate what one did, what was more stressful versus less stressful, and where one could do something in a different way, where one's stress is actually decreased. So you learn from the day and plan for the next day. These are simple things. These are micro steps, yes, which can actually help us a lot. Yeah. But lastly, there are some questionnaires that one can use, and some of these questionnaires have only 4 questions or 9 questions, and some of them are available on an app, which takes a minute to actually fill up. And they keep a record of your anxiety level, stress level over the day, as well as over multiple days and weeks. And one can see where one's stress level is and then plan for that. For example, there could be certain situations, certain shifts in the day, or if I can say, interaction with certain superiors, which might be very stressful. And you can know that and plan for that in advance. So these are some of the very simple things. I'm not talking about psychotherapy. Yeah. I'm talking about things that you can do yourself,
yes,
to protect your mental health and well-being, yeah, and to plan better and to look after better, which will have a tremendous impact immediately as well as over a period of time.
I mean, it often does come back to some of the simple steps that are also quite difficult to keep in mind when you get stressed, but they are very, in their own way, quite, the way that I hear it is sort of connecting with yourself and with others in very simple ways, and having a sense of structure, grounding yourself, preparing yourself, reminding yourself of things that may be stressful in the day ahead, the different rhythms of the day, the different periods of the day, just the usefulness in terms of emotional well-being.
And in fact, Chris, one of the very simple micro steps is breathing exercises.
Yep.
Just taking 10 deep breaths before you handle a major stressful situation. can actually put your body and mind in the best position to do your best.
Yeah.
Rather than to shift from one crisis to another. Just take 1 minute and then do it. That really helps.
Do you have your own ideas, your thoughts about, if someone does do those things or isn't able to for whatever reason, do you have your own idea of where it begins to just move from just keeping a sense of well-being into burnout or serious stress? Do you have your own markers that it would be useful for people to be aware of in terms of their own personal lives?
Yes. In fact, burnout is something that has been extensively researched upon, and also for doctors, especially for doctors, because the burnout rate amongst doctors is very high.
Yeah.
Burnout is a process, so one cannot really put a line as to where burnout occurs, and it's certainly not a static situation. But some of the early alerts are when you find yourself in the work situations more stressed than usual, so much so that your performance is impacted. So even a subjective sense of how you are doing today versus how you did a month back or a year back,
Yeah.
you already get an idea that you are in some way less effective. You have difficulty in coping up with situations. You have difficulty in performing to your best level. You tend to forget things. You tend to find situations more frustrating, and you become more irritable. So these are the early signs of that. And one important sign is that you take that stress back to home. So you not only are irritable during the work situation, but you actually, it affects your home life and your relationship with other people, including the families and colleagues. So those are the early signs. But when it develops more, your work performance is impacted in a very major way, so that other people start noticing, not only yourself, and also your control, your perceived control over the situation goes down. So you suddenly find that you have difficulty in realizing and functioning in the same situation that you had earlier, and you tend to lose control. So you are dependent on the situation rather than dependent on yourself. And in fact, doctors are very famous for saying, I can handle everything. And that sense gets compromised. And you suddenly start feeling that you cannot cope. And that is the beginning of a burnout. And eventually, of course, if the burnout is very, very advanced, then your work performance is less. You start making mistakes. And those mistakes, you sometimes feel that you have done it, so you realize it. And sometimes you don't realize it, and other people have to point out. And lastly, I just want to mention that doctors are very bad in discussing their own mistakes and colleagues' mistakes. So of course, there are formal occasions where these things are discussed, but informally, we hesitate a lot in telling somebody else that maybe that could have been done better, or flagging the issue that some of their colleagues might actually be in a situation that they are not doing the best which is possible for the patients. And so this goes unnoticed for months and sometimes years, and have sometimes disaster consequences for the care that they're providing, and especially also for themselves.
I mean, do you think it's particularly pronounced within the culture of the medical profession? I mean, do you think it has a particular...
Absolutely. In fact, medical culture, especially for doctors, I think nurses are a little bit better. They chat more, doctors chat less, and especially they tend to avoid some of these very sensitive subjects, which include their own mental health and others. And I'm talking to a whole bunch of Britishers, but I must say that UK as a country is especially very hesitant in discussing that. Many of the Asian and African countries are much better in that. They sit in the doctor's room and can chat about all of these things openly. But not too many people in UK. And I can tell you from my own experience, I've spent some time in UK, and there are many friends who are great colleagues, but the boundaries are extremely well maintained, and mental health and well-being doesn't fit in those boundaries somehow.
And is it, there's a difference between the UK and US culture? US is more comfortable or more familiar, more normalized this as a part of the conversation?
Yes and no. Yes, because I think they're more open to discuss these things, but no, because they're also more legalistic. So they fear the consequences of kind of discussing this and in a more formal way to report it. And so, yes, the barriers are there still.
Yes, yeah. And so going back to the systems, do you have, just building on the responsibility of the system, do you have clear examples of how to combat some of the things that you've just been referencing?
Yes, in fact, a lot more can be done than is being done. And I would say part of it is informal, like the stories that I described earlier, or assigning some time for discussing these things, starting from the top. So the top management must join those discussions and be as transparent, as open as possible. But then there are certain structural and functional barriers which they need to remove. And let me give you an example. The healthcare system looks after the insurance, health insurance of the staff members. But very often, mental health is covered in a way that doesn't do justice. And sometimes there are limitations on how much you can use and what you have to declare. And there is not a clear segregation between your health records and your human resources personnel record. And if there is a dilution in that, or even if there's a perceived contamination there, people will not seek help. Because if they know that if they ask for a consultation from a psychologist, for example, which is paid by their health insurance, and that information somehow is part of their personnel file, they will think twice, thrice, 4 times before they do that. In fact, sometimes I am aware that people go outside their health insurance to seek help, just to make sure that it doesn't affect their career. Let me give you another example. In many of the forms that we all fill up every year for licensing, our renewal of our privileges, there are sometimes questions about whether you have sought mental health care. Just like sometimes there is a question about whether you have tuberculosis. And that can be extremely damaging, because then either you're asking people to speak lies, or you're asking them to declare and then face a medical board. Nobody wants to do any of these things. So these are some of the barriers that the organization needs to remove systematically to make sure that there is a parity between physical health and mental health. And that, unfortunately, is still not there. So these are things that the organization can do very clearly, very deliberately, and with enormous benefits.
I'm aware of the time, and we've got to move to, I think there's been quite a few questions that have come in, but just in terms of so far, that's been a wonderful kind of dive into some of the specifics that, I mean, the UK doc, I mean, you know, it's in the title, isn't it? I mean, that's what we're trying to make much more normal and much more available to people. And just this conversation in itself, I think, it becomes another version of that straightforward human connection between people. Just being able to articulate, inform, and in a way inspire people to be okay with their emotional and mental health. So thank you. Anthony, are you able to come back and join us?
Hello again. So we've got quite a lot of questions that have come through, if that's okay. So first question is, how can doctors create steps to promote their mental well-being in teams with ever-changing expectations during times where pressures evolve day to day, as they have been and will continue to during the endemic COVID crisis? And what lessons can we learn to develop systems to protect or future-proof the mental health of these people going forwards, and as we look to emerge from the pandemic?
Which bit of that question do you want to answer?
There are many questions there, but I will try to touch upon some of these aspects at least. I think there should be an attempt to develop predictability when there is a lot of unpredictability for the day, for the week, for the kind of work that you're doing. But that's exactly where individuals can play some role, but the organization has to play a much larger role to make sure that people are not put in an impossible situation where they feel stressful and they feel morally bound to go out of their way to actually do things which you cannot expect them to do well. For example, a doctor is looking after, on an average, maybe 6 patients or 8 patients in a particular ward, and suddenly the person is asked to look after maybe 20. Now, the organization may not be able to prevent that, but the organization can make it easier for the doctor to do that work by putting some functional guidelines and making sure that there is some additional help available and there is a very clear path of prioritization. Now, let the doctor not prioritize, let the system prioritize, because otherwise you're putting an unnecessarily burden on the doctor to be able to forced to decide whether he or she should look after one aspect or the other one. That's what I call injecting some predictability and order into an impossible situation. I think that is very necessary. And we are developing those systems, but we are still far short of doing that, which obviously is also important for the effectiveness of the services. But I want to say that besides effectiveness, it should also have the consideration of that person's mental health and well-being. Let me give you another example. A doctor is looking after somebody in the ICU, and because of limitations in visitors and isolation and quarantine, no family member can take part in the conversation with the person. The person might be intubated, there are other problems. So the doctor or the nurse are the only people who have a direct access to that person. And that person might be very seriously sick. That person might be actually dying. And the doctors are looking after the last few hours and minutes to spend with that person. It puts an impossible emotional strain on the person. Are we doing something to take that into account as a part of the duties? And are we putting enough protective mechanisms so that person is supported in doing that impossible task and giving credit to that and also giving time afterwards so that the person can actually recoup well from that situation? None of these things are being done in a systematic way. And I would say we must start doing that as organizations and as individuals also.
So, I mean, so in a way, the first thing is just recognizing the truth of what you said. People in those situations, impossible situations, just the truth of that, the emotional challenges, the things that people have to navigate. And then, do you have an idea of when you talk about time? You mean literally time that for them to be away, to be apart, or to have time to talk, to engage with the experience?
Absolutely. Although I'm aware that the task is too severe and time is a very precious commodity, but it is in the longer term interest of the organization to keep time for that. Time in a day, maybe between 2 shifts, and time beyond a few weeks of that kind of work, because otherwise you are facilitating burnout and too much stress, and that has to be really looked after much better than what is being done right now.
I mean, in a way, in the way that I'm hearing what you're talking about, it's confronting the fear of these things in a way. There's one way or another, there's a fear, whether in terms of reputation or how you'd be seen in your own strengths or resilience, or just a fear of talking about these things, that talking about them in themselves, it would be too much.
Exactly, because we are all human beings, and we have a tremendous capacity to function in stressful environments. Yeah. But that capacity has still limits, and we need to recognize that.
Yeah.
Okay, so I've got another question here. So burnout rates amongst doctors are quite high in the UK. Recently, the BMA quoted 60%. And this questioner wonders kind of who's responsible for physician mental health in the United States, and are there any good examples from hospitals or hospital networks in the United States who've been able to help support physician health and well-being?
Yes, very important question. And burnout rates are also high in the US, comparable figures, as opposed to UK, where there is at least a good sense of who's responsible. In the US, it is much more chaotic, I must say, because there are health management organizations, health insurance organizations, hospitals, hospital systems, and all of that. So there is a lack of clarity about who's responsible for that. And of course, there are also associations which are involved in that. But yes, there are some good things happening, especially during the COVID period. And we are very aware of hospital systems which are taking very proactive steps to look after and protect the mental health and well-being of the doctors and other health staff. Let me give you an example. There are hospital systems and university systems which are appointing chief welfare officers and wellness officers rather than just relegated to the human resources people, who obviously are doing their best, but it doesn't really come up to that level. So appointment of a senior management position whose only responsibility is to look after the mental health and well-being of the staff is something which is very important. Second thing is that as a part of the package, people are putting more money into providing services when they are needed. So providing the kind of counseling that might be needed sometimes, and facilitating that, and even providing very clear psychotherapies when that is needed, which can prevent burnout and eventually save much more money. Those kind of things are there. Besides, of course, awareness programs and apps and pamphlets and other material, which could also be, of course, very useful. So yes, the situation is not ideal, but I have seen a lot of good things happening in the last few months in the US, and also heard about things happening in the UK.
Anthony, in terms of your direct experience, because I was just talking before about the sort of provision that is available within trusts, organisations, and so forth.
Yeah. So locally, one of the acute trusts, psychiatry is totally separate from everything else in the UK, as I guess you're aware. So locally, one of the acute trusts now has a virtual doctor's mess. So anybody who any of the doctors who can work there, who are from kind of FY1s first starting out to more senior doctors, can all join the virtual doctor's mess and able to have a bit more of a conversation about how they're doing, which I think is quite helpful for some of them. And there's nationwide now online doctor's mess kind of things organised for junior doctors. I think there's a big recognition that most of us have regional teaching in some way, and there's been quite a lot of recognition that the regional teaching isn't just for teaching, it's also for checking on kind of how people's well-being is and how people are coping in different environments. And I think a lot of the regional teaching now have more explicitly thought, well, it's now virtual, how do we still keep that kind of checking in element in it? And I think that's been quite helpful. although some specialties have had their regional teaching cancelled. Obviously, psychiatry is impacted in a different way to intensive care trainees or general medical trainees.
Next question.
This one's a good one. I think we've asked this one before to a few different people. So where does the responsibility for resilience lie? A lot of doctors feel the burden is put on them to be resilient, but they feel that the team in the workplace has an equal responsibility for contributing to this. What are your thoughts?
Well, that actually comes to the heart of the question, the medic within the medical system. So I would say part of the responsibility, of course, is for the person himself or herself, because they need to be the first persons who should be aware, should look after, protect their own mental health and well-being, because it's in their interest. But I would like to really point out that too much has been put on their shoulders to be resilient, to be able to do this or that. And the organizations are not doing what they need to do. And I would like to propose that actually the organizational, the environment at the workplace and the duties are very largely responsible for the mental health and well-being of the people who work within that. So it's not your individual doing, it is the doing of the organization. And so the responsibility by and large should lie at the organization. You can do some things, but the organization must change things. They must change the way things work in the organization, so that people don't become overstressed and can seek and get help if they need. And that is the responsibility of the organization. And I think not enough has been said about that, not enough has been done about that.
Neil Greenberg, that we had on a while ago from King's College, and worked with the Ministry of Defence, and his thinking is the urgency for a moral care, moral responsibility to provide these services within medical settings.
I completely agree. It's a moral agreement that you have made with your staff, and you must fulfill that. But as I said earlier, there is also the economic side of it. Even if you give you're not interested in people's mental health. If you're interested in your organization's sustainability and effectiveness, you need to do that.
What's the next one, Anthony?
So physician suicide is a concerning issue in the UK, with statistics that are alarming when compared to the general population. There is research citing both the US and Australia as having similarly high suicide rates. How do we stop this alarming statistic increasing?
Well, that's a global phenomenon. Doctors are some of the most at-risk population groups for completed suicide as well as attempted suicide. One of the things that I hear very often is that doctors have the means to complete a suicide. So many other people have inclinations, but the doctors have sometimes access to the kinds of medicines that can kill you much more often. And so they are in some way, when there is an impulse, they make it possible when other people may not be able to make it. But that's really responsible for a very small percentage of the higher prevalence. Much of it is the kind of work that they're doing and the stresses that they are subjected to. And that's again where early alert signs are likely to be very important. Suicide prevention is, suicides are multifactorial events, and preventing suicide is a multidimensional effort. So not one thing can actually help in reducing them. But what we talked about just earlier, that there could be early signs of excessive stress and also of depression, of course, which is very often and not always a precursor to suicide, need to be really monitored well amongst this. Let's consider some figures. between 3 to 5% adults in any population is depressed at some point of time. In fact, at any point of time, and almost 10% at some point of time. And these are very high figures. It's unlikely the doctors are not subject to these kind of figures. And so if you imagine 100 people, 100 doctors in your hospital, perhaps 3 to 5 are clinically depressed. Many more might have depressive symptoms at any point of time. And do we know them? If we look around our hospital, do we know those 3 to 5 people? I don't want you to become paranoid and start thinking whether my colleague is depressed. But we are systematically ignoring this problem, and that leads to suicide. So as opposed to the common impression that if you talk about suicide, then the person is more likely to go for it, it's just the other way around. If you ask people how they are, whether they're feeling in some way disturbed or depressed, whether they're feeling anxious, and then, of course, in a very trusting relationship, if you ask whether you have thought about ending your life, many times the persons are very willing to talk about it. And that could be the first step towards seeking help and getting help. So let's not hesitate. I'm talking about what we can do as individuals, as friends, as colleagues, as family members. We can do a lot, and especially for doctors, just to keep a tab on how the person might be feeling, to talk, to advise, to help, to support, and if needed, ask them to take formal help. This is something that all of us can do, and we should start doing. Obviously, suicide prevention is much more than that, but this is something that we can do ourselves.
I mean, I know with the work with people that I've worked with, either the suicide in being able to talk about it is proof of their desperation, and or proof of their own worthlessness. So the sense of shame to beginning to push back against, and in some ways, why wouldn't you feel like that at times based on what we're describing, what we're talking about? In some ways, it seems in its own way a response to situations, but it isn't necessarily something that someone's going to do, but the level of despair or bleakness could easily translate into suicidal thought, feelings. So again, I'm just reminded, not so much normalizing, but including it as a part of a spectrum of things that we can face in the work that we're describing.
Yep.
I just wondered, kind of had a follow-on question to that. Have you got any feeling, or are there any statistics that maybe suggest that healthcare workers' risk of suicide has increased during the pandemic?
We don't have very clear data on that, Anthony. And perhaps there is a latency period. Perhaps there will be many more attempts and suicidal deaths in future. Because it's seen in many crises that when the crisis is actually happening, the suicide rate actually comes down. But then after a time, the rate increases. So that we have seen in many situations, and that might well be true here. But there are obviously media reports of doctors dying because of suicide. There was a well-known case in a New York hospital, which attracted a lot of media attention. In fact, that has now become, from the family of the doctor who died because of suicide, there is a foundation that is actually taking up the issue at a legal and administrative level, and also for advocacy, to ask for more resources so that these very unfortunate happenings don't occur again. And I'm sure there are some cases in the media in the UK. But these are anecdotal reports, so I am not able to say that there is an actual increase in the number of attempted suicides or suicidal deaths. But I would be very surprised if that is not the case, because we have seen it in many other situations. And this situation, if at all, is much more stressful for healthcare providers than some of the other situations that we have seen. And also, a very large number of providers are affected by this. You know, if something happens in a particular city then you have maybe 200 doctors involved. In this case, there are thousands, tens of thousands doctors in each country that are being affected. So I'll be very surprised if that consequence, very unfortunate consequence, doesn't happen in reality.
I mean, part of UOK Doc was, I mean, Dan Gearan, the founding trustee of UOK Doc, one of his family members was within the medical profession, committed suicide. And that was part of his informed and inspired, motivated him to set up the charity. Anthony.
Yeah, so kind of this is moving kind of the conversation slightly to a different way. So it's a question about kind of what can the healthcare systems actually do to try and help improve well-being and mental health among doctors. I think this comes from experience in the NHS, certainly, is that a lot of organisations do have a lot of kind of seminars about well-being or have kind of specific ideas about doing well-being activities, but it's not really embedded into the kind of organisation itself. It's kind of a thing they do, and it's not embedded into the whole of the way they work.
Anthony, that exactly is the point that we need to make. It is not something that is done as an add-on. This should be part of the responsibility, part of the regular working of the organization that we need to do. If we haven't done it so far, this is the time to do it, because the need is very high and the receptivity will be very high. So I would say a few things need to be done by each of the organizations or institutions that are responsible for employing doctors and providing healthcare. One is that it should be part of the mission and the vision of the organization. It should be clearly mentioned in that. It should be part of the strategic plan, and it should be led by the top management. It should not be relegated to a person who's sitting in a corner and doing his own thing. It should be part of the responsibility of the top management, who should be willing to talk about it. And finally, it should be financed so that there is a specific budget for that. It's not that it's a charity, it's part of the organization's work. There has to be a budget for that. And lastly, it should be monitored. So the mental health and well-being of the staff needs to be monitored carefully. A report should be there as a part of the annual report, and the impact of any intervention that the organization is starting needs to be monitored and reported. That is the only way to do things which will really serve immediately as well as in long term.
Okay. Another question. So building on your work as a professor of global mental health at Harvard, if you were a professor of mental health for all healthcare professionals, what core topics do you think healthcare professionals should be taught to prepare themselves for their future career?
Well, that is something which I have thought a lot about. So actually, the education and training for mental health and well-being in the initial training of doctors and also for other healthcare providers is very deficient. We tend to focus on disorders and not on health. So are we training doctors only for diseases, or are we training them for health? Is a fundamental question that we need to ask ourselves. And if it is the latter, then we need to talk about what mental health and well-being is and how can we protect it and prevent disorders and diseases to develop, rather than to teach every minute details of the disorder and how to treat that. So that is the fundamental change that we need to do, not only for mental health, but for the entire health area actually. So is it that we are teaching people to remain healthy with their hearts and brains, rather than to look after the coronary artery disease and the dementias? I tend to feel that there's a change that is necessary at a very large level there. And mental health and well-being are part of that. In fact, I have seen many textbooks and curricula. The well-being as a word doesn't even occur there. It's not even mentioned there. And it is part of the Sustainable Development Goals of the United Nations. And we are not following that. So there is a fundamental change that we need to do at a curriculum level, at a training level. But then more practically, we need to have sessions where people talk about mental health of others, but of themselves also. And this should be done during their studentship so that in their future career, doctors are accustomed to doing that and can then monitor not only other people's mental health and diseases, but their own. And that will be really a wonderful thing to do. So I would very much like to suggest to the deans of the medical colleges to think about this and see how they can actually start building this as a part of the training so that the future doctors will think about mental health and well-being of their patients, of their colleagues, and for themselves.
Thank you.
That's a great answer.
I was thinking then maybe we need to get somebody in medical education on one of our webinars. It'd be quite an interesting viewpoint. So it seems that efforts are ever increasing, but is the impact we are having working? Are we winning the fight against ill mental health in doctors?
Do you want a real answer or do you want an optimistic answer? But I think the reality is somewhere in between. I think there is much more awareness, there is much more attention, but not as much investment as we need. So I think it's a good beginning, but we have really a long way to go. And my clear message is that we can all do something about it, ourselves as individual doctors, as a team for ourselves and our fellow team members, and as organizational chiefs for our organization, and obviously for the country. So I think the responsibilities are shared, but let's just start doing what we can do ourselves in whatever capacity we have, in whatever roles we have, and then see whether we can really advance our knowledge, but also the way we actually do things. And the real effect will be when we start doing things rather than just talking about them.
I'm aware of time, and we're going to have to draw it to a close. But just as you've been talking, I'm just so struck by your passion and your commitment to evolving, developing the conversation, and your clarity about the importance of these things. I mean, maybe I'm being slightly over dramatic, but the sense from when you first started, that fire, that hunger to me is still very alive. And I know what you mean about being realistic or optimistic. I think a lot has changed. And at the end of the day, we're still working with humans. And that's an ongoing, there isn't an end to that in one sense. But just hearing your voice, your articulation and clarity about what we need to continue to pay attention to has been brilliant. So thank you very much.
Thank you.
Thank you very much, Chris. Thank you, Anthony. And thank you all the people who listened to it and asked some very nice questions. It was such a pleasure to join.
Thank you for your time. Much appreciated.